Good morning, America. Good afternoon, Europe and Africa, and good evening, Asia and Australia. And welcome back to our ISRT Facebook Live. This is the first episode for the new year of 2021. And welcome you all friends from around the world. We are here today because we would like to celebrate our friendship among radiographers and radiological technologists around the world. And the topic that we previously had for the webinar was about interventional radiology and interventional cardiology. So we have this special session to feature the role of radiographers in interventional radiography safety, and that would be international perspective. Today, we are so happy to have three speakers plus one from around the world to share the experience on this issue about safety in interventional radiology and cardiology, not only for us, it's also for the patient, which is very important because, interventional radiology is one of the very high dose modality when in our practice. So we will feature three speakers for today. The first one, we have Roberta Geracia. She is the president of the Italian Association of Interventional Radiographers from Italy. And the second speaker from South Africa, Jana Peters. She's from Groote Hospital, and she represents SORSA, the South African Society. And last but not least, we have my very good friend from Myanmar, my neighbor from Thailand, she's from Mandela Hospital, and she represents the Myanmar Society of Medical Radiation Technologists. And the fourth speaker will be myself. I will share with you a little bit about activities of my country, Thailand, in interventional radiology, patient safety. And last but not least, we have also special guests for tonight. We have Terrell. He's our ISRT Vice President for the America. Terrell will be the panelist for tonight. And of course, we have Madam President Donna Newman with us. So I would like to start today's program with Roberta Geracia. As I mentioned before, Roberta is the president of the Italian Association of Interventional Radiographers. We are so happy to have her. So let's start with Roberta.
Good morning, good afternoon, and good evening to everyone. My name is Roberta Geracia. I am president of ITRI, the Italian Association of Interventional Radiographers, and I am coordinator of a scientific committee of FASTER, the Italian Federation of the Radiographers Scientific Associations. I come from Italy, a small country located in South Central Europe that due to its central geographic location in the Mediterranean Sea, has historically been home to myriad peoples and cultures. Italy is famous for its capital, Rome, and it is still recognized for its artists, fashion designer, motors, foods, and monuments. And it has more UNESCO World Heritage sites than any other country in the world. Italy ranks number 23 in the list of countries by population, and including cath lab, it has about 330 angio suites. Within these angio suites, Italian radiographers, before procedures, perform daily quality control tests, provide the patient and staff shielding, make verification of the correct patient procedures and procedure sites. Radiographers are responsible for managing the equipment, ensuring a diagnostic quality of the image while delivering the lowest level of dose achievable. The aim is to get an adequate radiation dose and an image quality related to the image detail the interventionalist needs in real time. Radiographers check patient dose during the procedures, and they are responsible of recording all patient radiation dose factors and procedures acquisition parameters in the patient's medical folder. Finally, radiographers usually perform images post-processing, and they are also responsible for storage and transmission of all images obtained. In addition, more expert Italian interventional radiographers provide procedural scribing assistance. They work in close collaboration with the medical physics in dose monitoring software management and in the local diagnostic reference levels calculation. Furthermore, they are involved in quality assurance programs and interventional radiology research projects. To become an interventional radiographer in Italy is necessary a bachelor's degree in medical radiology, imaging techniques, and radiotherapy. The 3 years course aims to prepare students to either gain admission to apply for a postgraduate certificate, master's degree, or to enter directly the professional world within an imaging, radiotherapy, or nuclear medicine facility, including interventional radiology. Radiographer can represent a bridge between what medical physics do and what interventionalists need. But it is also possible if radiographers have an in-depth knowledge of anatomy, physics, of the main equipment involved, not only angiographic equipment, but also ultrasound, CT scan, and MRI. And they need an in-depth knowledge of these equipments, application, and operational activities. Also, in view of an integrated multi-professional activity, interventional radiographers need to have knowledge of procedures, medical devices, and sterile field. And they need a flexibility in behavior, in ways of thinking and acting in emergency situations too. However, the preliminary results of an ITRIS survey show that the total days of university internship in an interventional radiology department or in operating room in Italy change course by course. And in most cases, the number of days is not enough to ensure a good education in interventional radiology. All interventional radiographers should always keep in mind the risk of X-ray radiation both for patients and staff. In fact, during long and complex procedures, patient dose might exceed the threshold of deterministic effect. And even if we are using correctly shutter, severe injuries can occur in particular to patient's skin. Furthermore, because the total dose of operators in their career can be considerable, particular attention must be given to the staff radiation protection. And it is necessary to consider that it is not always possible using shields, and sometimes interventionalist hands could enter within the primary beam. As you well know, dose to staff depends on the patient size, the type of procedure, the experience with the operator, and the access route. But other factors are involved, such as the equipment used and, above all, its operation by radiographers. Also, it is important to know that despite technological advance can help us to achieve a high image quality with a lower patient dose, it often results in an increase of heat and in the potential for substantial radiation exposure risk for patients and staff. Usually, medical physics set up protocols for standard patients based on equipment architecture and intended use. However, during the procedures, we can have many different patients and situations, and medical physics is often not within or near the angio suite. So it is essential that all interventional radiographers learn how to adjust the parameters of the automatic exposure control system to fine-tune radiation dose for different clinical indications and body regions. In Italy, to close the gap in education, skills, and training, ITRI, due to scientific and educational role representing, in synergy with the University of Bologna, promotes a master degree in interventional radiology and neuroradiology. Also, we promote webinars designed to promote the theory from the basis, to share high-level professionals' experiences, to be in line with high-level technologies and cutting-edge interventional procedures, to encourage the evidence-based approach and to promote interest in research. For the future, we need to invest in internship and placement as essential activities to transform the knowledge acquired into professional skills. We need to consolidate bases for a specific interventional radiology qualification perspective that allow a career development. We need to standardize education. Also, we need to promote collaboration with medical physics, radiologists, and nurses to foster a culture that protects patients and all staff working within the angio suite. And above all, we need to increase student interest in interventional radiology, conveying to them the importance of our contribution to patient and staff safety. Thank you for your attention.
Thank you so much, Roberta, for your very comprehensive talk. And we did see that the practice of our friend in Italy for interventional radiography is very advanced, and I'm really happy to hear that. And now let's move to the next speaker before we come back to you for the Q&A session. We have another speaker, our friend from South Africa, Yanda Peters, and she is representing SORSA. And Yanda will tell us about the situation in South Africa. Please welcome Yanda Peter.
Good day, ladies and gentlemen. My name is Yanda Peter. I am a lecturer at the Cape Peninsula University of Technology in South Africa. Today, I'm going to be presenting on the role of radiographers in interventional radiology safety, a South African perspective. It is a privilege for me to be presenting here today. Therefore, I would like to thank the ISRRT organizers for the opportunity. Before we get into it, I would like to give you a brief overview of my country. South Africa is a country at the southern tip of the African continent with a diverse multicultural population of about 59.8 million people. The healthcare system in South Africa consists of the public healthcare sector and the private healthcare sector. The public healthcare sector services the majority of the population. Currently, the healthcare system in South Africa is under severe pressure as the country is battling with the second wave of coronavirus. There are 26 universities in South Africa, 8 of which offer radiography training. Now we move on to today's topic, interventional radiology. Interventional radiology procedures are image-guided interventions which are usually performed under fluoroscopy as an alternative to surgical procedure for the treatment of various conditions. Advantages of interventional radiology over surgical procedures include their minimal invasiveness and the short hospital stay for the patient. However, interventional radiology procedures can result in high radiation doses, which could cause deterministic effects to the patient. For this reason, radiation protection is crucial in interventional radiology. Interventional radiology content is covered in radiography training at all institutions in South Africa. It is introduced at different levels, with the introduction at third-year level in some universities, while others introduce interventional radiology at fourth-year level. The Cape Peninsula University of Technology and the University of Pretoria also offer an elective in interventional radiology. However, it is important to note that at the Cape Peninsula University of Technology, students do not get enough clinical time or exposure in interventional radiology. Therefore, the required competency levels to practice as a radiographer in interventional radiology or as an interventional radiographer are not reached at the end of the elective or by the time the student qualifies as a radiographer. On-the-job training is offered to achieve the competency levels and to prepare the radiographer for the role as an interventional radiographer. The radiographer's scope of practice in interventional radiology. Now, this is based on my experience as an interventional radiographer at the Groote Hospital in Cape Town. The responsibilities or the role of the radiographer includes operating the imaging equipment, ensuring good image quality, radiation protection of both patients and staff, and also ensuring that quality assurance is performed on the equipment at the prescribed intervals. The radiographer is also involved in patient preparation, for example, confirming that the patient doesn't have any iodine allergies before the injection of contrast media, and that necessary blood tests have been performed and that the results are within acceptable levels. The radiographer also assists in patient care, although this is mainly the responsibility of the nursing staff. The radiation protection in interventional radiology, as already mentioned, is very important. ALARA principle is used to apply the radiation protection in interventional radiology. And this principle, or ALARA, in interventional radiology is applied by using the low acquisition frame rates, the low fluoro rates, as well as collimating to the smallest possible field size. Shielding also plays a crucial role in radiation protection in interventional radiology. Shielding is in the form of direct shielding on the patient, a ceiling-mounted LED glass that is positioned between the imaging equipment and the operator during the procedure, as well as table skirts, which are LED shields that are attached to the imaging table for the reduction of the scatter reaching the operator during the procedure. Staff also wear LED aprons, the thyroid shields, as well as LED glasses, which are optional, by the way. The LED glasses, the LED aprons are 0.25 and 0.35 millimeter LED equivalent. The interventionalist is always advised to use the 0.35 millimeter LED equivalent LED apron for optimal radiation protection. The position of the image receptor or the flat panel detector plays a role in the reduction of scatter during the procedure. It is thus important for the radiographer to know the position that will be best for reduced scatter. For example, positioning the flat panel detector as close to the patient as possible, as well as positioning it on the operator's side for the lateral views, leads to reduced scatter. The radiographer's knowledge of the anatomy and procedure also contributes to the radiation protection, as this knowledge would allow the radiographer to collimate to the required field size and also to position the LED shield properly without overlapping the area of interest. Radiation dose reduction technologies incorporated in modern equipment also play a huge role in the reduction of radiation dose in interventional radiology. The radiographers face challenges in the performance of their role as or in radiation protection. One of the challenges is due to the fact that interventional radiology procedures are also performed by non-radiology personnel, for example, the vascular surgeons, who have inadequate or no radiation safety training. This puts radiation safety solely on the radiographer's shoulders. Now, this in itself can be a challenge because in some cases, the radiographer is not fully recognized as a professional. Therefore, their voice is often not heard. This makes it difficult for the radiographer to ensure radiation safety. For example, when trying to get someone or the staff members to wear appropriate radiation protection gear, this is often met with resistance because the radiographer is not recognized as a professional. There is misconception that the radiographer's role is just to provide imaging when requested. As a way forward, I think it would be ideal that radiation safety training be offered to all staff members involved in interventional radiology, including surgeons and nurses. And there's also a need for regular update of the radiation safety knowledge. And I would also encourage the radiographers to continue addressing the radiation safety issues despite the challenges they face. That is the end of my presentation. Thank you.
Thank you so much, Jan and Peter, for your presentation and let us know about your current practice in South Africa. We will come back to you during the Q&A session. For the audience from home, wherever you are, if you have any questions or comment, please do so in the chat box. It's going to be right underneath your screen, or it may be on the right-hand side, depending on the platform that you are watching at the moment. And the next speaker is my very good friend from my neighboring country, Myanmar, Yin Neu. She is from Mandala Hospital, and she is representing the Myanmar Society of Medical Radiation Technology. Please welcome Ms. Yin Neu.
Greeting from Myanmar, Minglawa. I am Yunu. First of all, I would like to say special thanks to ISRT and MSMRT. I would like to talk about role of radiographer in interventional radiology safety. Let me continue. This is our country, Myanmar, current land. Republic of the Union of Myanmar is a country in Southeast Asia. According to 2019, population is 54 million. Capital is Naypyidaw. Official language is Myanmar. Many popular places in Myanmar: Mandalay Hill, Mahamyamuni, Chiragong Pagoda, Sakai, Patkan, Ubin Bridge. Welcome to Myanmar. Interventional radiology is a medical specialization performing a range of imaging procedures to obtain images. The interventional radiologists carefully interpret these images to perform interventional medical procedure. Many specialties are combined with interventional radiology procedure: cardiac, neuro, nephro, fertility, oncology, pain, and pain. All about radiographer I am practicing in Myanmar. Naypyidaw 100-bedded hospital. Cardiac department started in 2018. Nowadays, total patient 265 patients. And then Manly General Hospital. Interventional radiology started in 2004. 95% is TACE and others 5%. Cardiac lab started in 2001. Nowadays, total more than 5,000 patients. Radiofrequency ablation cases started 2016 and until now 150 to 200 cases. This picture shows interventional radiology at Mandalay General Hospital. In Yangon General Hospital, interventional radiology started in 1965. Almost 8 cents are TACE. 4 to 5 patients per day, 3 days only per week. Cardiac department, patient accept 10 patients per day. Some private hospital at Yangon doing interventional radiology. Bala International Hospital, Grand Hatha International Hospital, HRI Hospital, Bahusi, Penlo Kantaya Hospital, only one at Mandalay City Hospital. Morris and Asia Pacific Society of Cardiovascular and Interventional Radiology Cooperation workshop is aimed to improve the level of clinical practice and research of cardiovascular and interventional radiology in the Asia Pacific region. This picture shows First to Fit MRS APS CVR workshop started in 2016 to 2020. All about our education and training in Myanmar. We learned basic knowledge of radiation protection at second year level. On third year and final year level, we know about biological hazards and radiation protection for interventional radiology, both theory and posting at public hospital. Master level, IR technique, applications and radiation protection for IR, both theory and posting at public hospital. There are common interventional radiology procedures here. Any challenges as radiography profession to perform the duty in IR and IR safety for both patients and radiographer in Myanmar. Actually, interventional radiology is teamwork. We need to coordination with other members. Interventional radiology is innovative, minimally invasive diagnostic, effective and therapeutic. We have to emphasize radiologists and radiographer skill. This is a big challenge. Both roles and responsibility, hence are very important to provide quality and service. We have to perform patient safety checklists. For every patient receives safe care every time. This is very important because interventional radiology is minimally invasive. Various risks and complications can still occur. And then for patient economic burden, adverse events are usually caused by multiple factors rather than single factors in isolation. We have to do procedure planning, sign in and sign out. We have to review imaging study, request informed consent, and explain thoroughly to patient. And then relevant lab test is requested, contrast allergy. We have to check correct patient, correct site, and correct site. And then monitor equipment are attached, consent including complication and discuss with physician and patients. We need to check vital sign, normal during procedure. Lab tests are requested, hot samples, liver, and central lab. Procedure results are informed to referring physician. On about radiation protection in IR, we have to use dosimeter to measure the dose received are not above the limits established. The limit for the affected dose is 20 millisilver per year. No matter what event, we have to obey a LARA principle as low as reasonably achievable. Ceiling hand sheets. Mobile sheets are suitable for nursing and anesthesia. Lead drips hand down below the table. We have to put between the X-ray tube and the walker to reduce the doses received. For personal shielding, apron, alright sheet, cap, glove, and goggles. Actually, in fluoroscopy, scattering is very dangerous. Many factors can influence on scatter. Patient size, angle of the image acquisition system, use of sheets, and method of fluoroscopy. We have to obey in vascular law. If the distance between the walker and the radiology table is double, radiation exposure will drop to 1/4 of the initial value. How to minimize risks? Only when we have to reduce beam on time. We have to use as short as fluoroscopy on time. We can use freeze image on the same anatomy region. And then low-dose image marks automatic exposure control and low frame rate. Area of interest is irradiated. This close collimation is essential. And then not only improve image quality, but also reducing radiation scatter by collimation. Scatter radiation levels are highest in regions close to the equipment. That's why we should stay away from these sources. Sheets or 0.1 millimeter lead equivalent are placed on patient. Proper position is a key to reduce operator doses by 44%. The patient should be positioned as far as from X-ray tube. The image receptor should be as close as possible to the patient to maintain image quality and to reduce radiation dose. Quality control is very essential. Qualified personnel under the direction of a medical physicist perform the tests on all imaging system and personal protective device. Image quality, radiation output, automatic exposure control operation, visual inspection of personal protective device for physical imperfection. Radiographic imaging of the apron should be performed if the device is suspected of any defect. We have to perform annual performance of routine quality control tasks. We have to check visually the aprons frequently. If a defect is detected, operators should radiographic examination on the apron. We have to handle like that. Good radiation safety practice. Wear dosimeter consistently and properly, wear affected personal protective equipment, proper fluoroscopy training, good planning, protective sheeting. To eliminate unnecessary radiation exposure, to promote radiation protection awareness. Very important in recent conditions, checking for preparing our service for COVID-19 by appropriate checklists. That's why we have to protect patients and healthcare workers from contaminated or infected, providing safe care for the patient. Conclusion. Some radiation safety practices that maximize both protection and comfort. Striking this balance between safety and comfort is critical. In parallel, other specialists are performing more fluoroscopically guided procedure by understanding the essentials of radiation physics, radiation protection, and the unique features for each imaging system. Interventional radiologists can embrace this opportunity to champion robust radiation safety practices and educate trainees, staff, and colleges across specialists. Interventional radiologists can establish themselves as experts and leaders, underscoring their value to colleges and the hospital administration. These are my reference. Acknowledgement. I would like to say special thanks to Mr. King, President of MS Amati, Dr. Milu, Senior Consultant Radiologist, and then MGH Curriculum Lab, Nibido, 1000 bedded hospital for providing data. Especially Dr. Jamue, Acting CEO, Mandala Hospital, supporting me in preparing this presentation. Thank you. Thanks a million. Good night.
Thank you, Yineo, for your presentation, and it's quite eye-opening for us to see what are you currently doing in your country, Myanmar. And another 10 minutes also, I also would like to present what's going on in terms of quality and safety in interventional radiology in my country, Thailand. And this is my turn. Good morning, good afternoon, or good evening, wherever you are in different part of the world. My name is Napapong Napang. I am the president of the Radiological Technology Board of the Kingdom of Thailand, and I am also the vice president of the ISRT. I would like today to talk about radiation safety and quality management in interventional radiology in my country. The content of my talk, I will introduce a little bit about my country and our healthcare system, and about radiology in Thailand in terms of safety and quality, and also about quality management and quality audit that we are doing at the moment, and focus a little bit on the topic for today, radiation safety in interventional radiology, and I will conclude with the way forward, what we are going ahead with. Kingdom of Thailand, founded as United Kingdom of Ayutthaya from loosely independent states at that time back in 1351, and we cover area with size pretty similar to France, about 500,000 square kilometers, and we have population about close to 70 million at the moment, and we have ethnic content that form the population, the Thai, the Siamese, the Lao, the Chinese, the Malay, and the other ethnic minorities. With this population close to 70 million people, and the World Health Organization classified Thailand as upper middle income country. Radiology in Thailand started back in 1898 by Professor Hans Adamson. He is a royal court physician who brought the first X-ray machine to the country. But not until 1928 that we founded radiology education and training in Thailand by Professor Pin Merman. He worked in my university, Mahidol University. He is our pioneer radiologist who graduated from Harvard University from the US. And at present, Thailand has close to 2,000 radiologists, 200 medical physicists, and more than 5,000 radiological technologists or radiographers practicing in the healthcare system. For radiation safety and quality management in radiology, main radiation safety control is under the Nuclear Power Safety Act, which was updated back in 2016. And radiologists and technologists' professional practice are controlled under the relevant professional law, while the medical physicist licensing will be affected by this year 2021. An updated regulation stipulates that all radiation emitting machine in diagnostic radiology and dentistry now are required to be registered at the Ministry of Public Health. An annual survey and quality of the equipment is required to be performed by the physicist. We collaborate with the International Atomic Energy Agency, the IAEA, for the quality management and clinical audit. As the United Nations member states, Thailand has been very active participating in such activity with the IAEA. And following the corresponding requests, usually linked but not limited to the relevant technical project, the IAEA is responsible for forming an audit team, giving international perspective and assuring the principle of independence between the auditor and the audited department. And we already had some of the big radiology department audited by the IAEA, and that include Interventional Radiology Service. For clinical audit, what they are looking at, this quadrille scheme is intended as an independent assessment of how actual clinical practice compared with good practice, and this is pretty much peer review evaluation, and they would look at staff, equipment, procedures, patient protection and safety, and overall performance of the facility, and that include interaction with external service providers. Back to our topic, in interventional radiology, what have we done so far? We have a standardized training for radiologists, interventional radiologists, for the technologists, and for the physicists in the country for almost 100 years. And for interventional radiology, this is pretty much a recent project that we are working on, especially to establish the diagnostic reference level and establish the national guideline on patient dose monitoring. And this meeting was held last year in collaboration with the Royal College of Radiologists, the Medical Physics Society, and the Radiological Technology Society. We do train the physicists from the Ministry of Health to go around the interventional radiology centers to calibrate the dose area product from different machines to make sure that the data to be collected are correct in terms of dosimetry, and also with the standard protocol that we want to collect for the dose data. The technologists and radiologists and the physicists, we came together and come up with the agreement of which procedures that we will collect the data, and also what kind of dosimetric parameters that we would like to include. And here's how it looks for fluoroscopic dose indicators. Basically, we collect for two things. One is for optimization, that is the Kerma area product or the dose area product. And the second part is we are also looking at the deterministic effect or the skin effect, because those from interventional radiology is quite high and can create the skin reaction. So we would like to come up with the national guideline for this. Normally with big centers that we have, that the hospital that provide interventional radiology service, they are likely to have this dose management system. In this dose management system, it links to the modality and to the PAC system. So what we can do is we can retrieve or pull out the dose data that we expose to individual patients that came in to our service in interventional radiology. So we get pretty much all the dose parameters. The thing is, we would like also to have the national guideline on how to manage the skin reaction or skin threshold dose. We know that the threshold dose is about 2 grays or 2000 milligrays that can create the onset of early transient erythema or the skin reaction. So we have the guideline. Since the dosimetry is quite tricky here, and normally people who are responsible for this are the technologists or radiographers, because we are on the site, not the physicists. In Thailand, we only have the physicists come in the hospital from the Ministry of Health once a year to do machine calibration, to do dosimetry and quality assurance. We adopted the guideline from the US, from University of Texas MD Anderson Cancer Center, and this was published in Radiographers. The patient follow-up for high-dose procedure. Normally, what we come up is that if the cumulative air kerma is more than 3 grays, then we will do the record and inform the interventionist to further management. And next one is about optimization. Part of the radiation protection to the patient is the diagnostic reference level, which is part of the optimization. With the purpose is we want to indicate whether radiation dose from routine procedures are usually high or low, because we know that in using medical radiation, we have to optimize the dose, and this project has been carried out by Ministry of Public Health since 2017. And currently, we have diagnostic reference level values for plain radiography, dental radiography, computed tomography (CT), and also mammography. And now we extend to include interventional radiology. This was the meeting, the workshop provided by the International Atomic Energy Agency, the IAEA. They sent the expert and then work with local staff, mainly radiographers or technologists, and some physicists and some radiologists. We come up with the plan to do dose data collection for interventional radiology, and those metrics that we will use include the dose area product or the kerma area product, and also cumulative air kerma reference point. And the list that you see are the procedures that we will collect the dose data to see the optimization in terms of diagnostic reference level. And those include both diagnostic procedures and interventional procedures in neuro and in body interventional radiology. The challenge thing that we face is that the dose reference level for interventional radiology is quite a challenge because first, DRL should be addressed and used as a tool for optimization for the IR procedure, and DRL quantity should be tracked for IR procedure. This will aid the optimization process. We don't say that if your hospital use the dose more than this is illegal or something. This is just the guideline so that you can compare yourself with the national data or international data. And one complex thing about IR, interventional radiology, is that even the same procedure but different patients, complication or the difficulty degree will be different. So sometimes we may have to think about this also when we do those data collection. I would like to finish this with the way forward. We have done quite a lot, and this year 2021 we believe that we will come up with Thailand National DRL for interventional radiology from procedures listed as I mentioned before. Quality and safety in interventional radiology service are key elements utilized by practitioners to ensure best benefit to the patient. We work for the patient, and we have future plan to establish Thailand's clinical audit system for radiological services that include interventional radiology with collaboration among professional bodies, including radiologists, medical physicists, and the radiological technologist or radiographer. And DRLs that we have will be updated for each modality every 5 years. Patient dose audit system is to be established too once we establish the national guidelines, and multi-professional collaboration is the key for this success. Last but not least, technologies of radiographers play important roles in both quality and safety for this interventional radiology. Thank you very much for your attention. Oh, thank you very much. This was just what's going on also in my country, Thailand, about quality and safety in interventional radiology. Before we go back to our speakers, I would like to have our panelists for today, the ISRT Vice President for the Americas, Terry L. Terry, hi Terry. You have any questions or comments so far? Would you unmute your microphone, Terry? All right. While Terry is fixing his technical difficulty, I would like to ask some questions first to the speaker, and these questions are from our audience. The first question is, what are your association in your country doing to help with education and recognition of radiographers as important part of the radiation protection expert team? The question from the audience, what are your association in your country doing to help with education and recognition of radiographers as important part of radiation protection team? So I would like to start with you, Roberta.
Idri, as a great an important role in education, as I said in my presentation, about radiation protection and about especially equipment, because we know that equipment are a part of our work, our daily work. So we decided to do a lot of webinars to promote knowledge of equipment, because in our opinion, the basis is to learn about the new equipment, and then especially the auto exposition control system, because usually in university course no one explain something about that. So we decided of not tell our association, our Italian radiographers about the normal strategies of radiation protection, but we want to say them something of new that is about equipment and in-depth knowledge of equipment.
Oh, thank you. And I would like to move to Yanda. What's your opinion on this?
Okay, so the Society of Radiographers in South Africa run frequent webinars and workshops, or not conferences, but rather webinars nowadays. So radiation protection is covered quite a lot in those webinars, but unfortunately, those are mostly attended by radiographers, who are people who already know their role in radiation protection. Is just really to emphasize the radiographers' role in radiation protection, and they, from time to time, they would have the medical physicist as well attending to give presentations. But in terms of the information going out there to other healthcare workers, I am not sure, but there must be something that they're doing. I'm just not aware of what is being done at the moment.
All right, thank you. And how about Myanmar? You have Are you still with us?
Yeah. Hello. Actually, MS MRT lead work so many workshops at Myanmar, also mentally in Yangon. MS MRT invited foreign countries, especially Thailand, especially Professor Napapon, to share knowledge about radiation protection. And then we had MRS associated with Asia Pacific, cardiovascular and interventional radiology, and then so many workshops. So we have to try hard for interventional radiology in private hospital because we are a few private hospital working at interventional at mentally. That's why we have to try more. Thank you, sir.
Oh, very, very, very good, interesting information that you have for us. And back in my country, in Thailand, we have a very active organization, especially for radiographers. We have Thai Society of Radiological Technologists, the TSRT. We involved with all the activities that the government requested, especially the past couple of years that we are start to work on the quality and safety of the patient. And interventional radiology is one of the key of the area that we focus on because in terms of radiation protection, we know that the dose to both patient and staff it's higher than other modalities. So that this is one of the focus that we have the training, the webinar, and also the on-site courses with collaboration with the Royal College of Radiologists. And also we have two interventional radiology societies. One is neurointervention and one is the body intervention from Thailand. Terry, are you back with us? Can you try again? No, you have to unmute your microphone, please. Oh, yeah. Still not. That's all right. I will go ahead with the next question then. This one is quite interesting because this practice, our practice may vary from one place to another. So the question from the audience is that in your hospital or your practice, do you have your own lead apron or gown, or you rotate with others? This is quite good question that we got asked all the time. Are you privileged to have your own lead apron or not? Start with Roberta.
Okay. I think I'm very lucky because in my hospital there is a great interest on radiation protection. So we have a personal apron, a personal thyroid shield, and needed high glasses. So each one have one of these personal protective needed devices.
Oh, that's great. Great to hear. How about in South Africa or in your hospital, Yanda?
Okay, so at Groote Hospital, or GSH for your ease, when the new stock comes, the order will go out and the stock will come. It doesn't come as in this is your apron, but what happens is that radiographers are usually the first people to get to the new stock. So they would identify the aprons that fit them best, that they like, and we would sort of like just each take one that we would put away where, we know that if we need an apron, this is my apron. And there's that common understanding. It's nothing formal, but there's that common understanding that this is so-and-so's apron, that is so-and-so's apron. But nothing gets ordered specifically for a radiographer. But when the new stock comes, then each radiographer will just pick one and put away for themselves.
All right, quite interesting. And how about you in Myanmar? Do you have your own apron or you have to share?
Yeah, actually, I have no practice at our private hospital. I just learned my master level at our government hospital, but I don't have own apron. But we have to. We had to do practice about that apron and she at our hospital.
Ah, okay. Quite interesting. And well, in Thailand, it depends on the place. So if they have a lot of money and they decided to have each of you to have the apron, then it's okay. If not, you have to rotate, and that's the current practice that we have. And I think the next question also come from Mr. Kim Mung Tin. He just asked me, so I'm gonna have to ask him, and then maybe I ask the other speakers too about how would you respond to this. Mr. Kim Mung Tin, the president of MSMRT from Myanmar, he asked about when the patient, what are the patient's reaction when they found that they have cumulative skin injury? That's quite tricky. Well, the fact is, after the IR procedure, skin reaction will not come right away, right? We all know that it takes time. The onset may be days or weeks. So normally when we do the dose, the notification, it depends on your practice. Maybe you start from 2 grays. Some people start with 3 grays. It depends on you do with peak skin dose or you do with the cumulative air curve. But what we mean to do is that we notify the doctors, the interventionists, about they may need to call back the patient for skin reaction evaluation within 2 weeks or something. Or if the skin patch has the dose burden quite a lot, 3 grays or more than that, 3, 6, 9 in some places that do this, then you have to inform the interventional radiologist or interventional cardiologist so that next procedures, they have to angle the X-ray tube from different angles so that to save the skin patch from irradiating to high radiation dose. So what about your experience on this? Roberta, I know that from your presentation, you have the dose management system on this, right? So please share your experience to us. I hope it's not too difficult.
Yes, I have this dose software for dose management in my hospital. It is very interesting because we can check in real time everything about patient exposure, about technical parameters, about threshold dose. In my hospital, we decided to choose 2 gray as a threshold dose because in our experience, our patient exposure is very, very low compared to 2 gray and compared to doses in recent literature. And our papers can show that it is true. So we prefer to choose 2 gray for adult patients and 1 gray for pediatric patients. And but I don't know what happens when 3 gray appear in the monitor because we have no experience of this dose for our patient. So because we manage our equipment accurately, so we have no 3 gray and no 2 gray for our patient.
Oh, that's a great news to hear.
Never. So we are writing something about this because I think it is very important above all because we perform every day very difficult procedures such as TIPS that are one of the procedures that give more doses to patients. And we have so many pediatric patients in our department. So I think it is a great result for us. And it is a result of collaboration close collaboration between radiographers and interventionalists.
Oh, that's great news to hear. And in South Africa, Yande, what are you doing with this skin reaction patient?
Our experience is sort of like Italy. So I was working in the interventional unit for 10 years. In that 10 years, I don't remember seeing a case where the skin dose was more than 3 gray, maybe more than 2 gray. But what we would do then, if the dose is nearing 2 gray, we would just alert the the interventionalist, who may be a radiologist or a neurosurgeon or vascular surgeon. So you just alert them to the fact that this patient received a high dose. And our patients in South Africa at the moment are not really, especially in the public sector, they're not very much involved. So they don't know when they receive a high dose. But the interventional staff would be aware that this patient received a high dose. In those years, I remember of one patient that was a regular patient for access loop studies that had skin injury, and she didn't know what it was. So when she came back for her follow-up, which was about 6 months from the previous time she had been with us, she just mentioned that, she developed this skin burn and she didn't know what it was. So she sort of like read up and realized it may have been a radiation injury, but it disappeared before she could worry herself more about it.
Yeah.
So
yeah.
that's our experience.
Good to hear. And in Myanmar, are you starting to focus on this, or you have something else to share about patient skin reaction or patient safety?
Yeah, actually, I have never been about the skin injury during interventional radiology because we have to take care as low as reasonably achieved. That's why I have never been about the skin injury in my master level to nowadays. It's very rare case,
All right. And
Yes.
one question from the audience was that how many days or hours that your radiography student exposed to clinical placement in interventional radiology? In my place is only 3 to 5 days. What about you in Italy, Roberta?
Yes, it is the same in Italy. And in my presentation, I show a slide, a picture with our survey's result about it. And it is incredible because 5 days are so few, so it is incredible. Yeah, I think we need to promote more days of education in interventional radiologies because the radiographers need to practice a lot with geographic equipment and with also the sterile field that it is important to be confidential with the sterile field in a geographic room or in an operating room. So I think we need more days than 5 or 10 days.
I do agree, and I got this feedback from our colleague, the radiologist, interventional radiologists too. Like they said that they need our student to get more exposed to the IR. But I told them, like in my country, in the 4 years bachelor degree program, we have to do diagnostic radiology, nuclear medicine, and radiation therapy. So there's no way that we can have student allocated for IR more than 5 days. So, but after they graduate and before they get to work, they can get extra training. And what about in South Africa, Yanda? What kind of situation that you have over there?
Okay, so the interventional cardiology department is separate from the interventional radiology where the rest of the procedures are performed. So our students at Cape Peninsula University of Technology start interventional radiology and cardiology rotations in their 3rd year. So each student will have 1 week of cardiology and 1 week of radiology. So that's 2 weeks in 3rd year and another 2 weeks in 4th year under normal circumstances. But with COVID-19 now, we're not able to place them as normal. So in total, they get about 4 weeks during the duration of their training.
Oh, in your training, you do 3-in-1, like diagnostic, therapeutic, and nuclear medicine, or do you just imaging or therapy?
Yes, you choose one. So it's either diagnostic radiography or ultrasound or radiotherapy or nuclear medicine.
That's how you have more time than us.
Yes.
That's quite interesting. What about in Myanmar? You have been a teacher also. how did you manage your student for interventional radiology placement?
Yeah, we have to learn about fourth year and master level to learn interventional radiology 2 days per week, and then format. We have the two department. For example, Mandalay General Hospital radiology department, we can learn interventional radiology, and then cardiac cath we have to learn cardiac replacement and sending coronary angiography. These are two block posting in format per year. So for final year and master degree only, 2 days per week.
Oh, quite interesting. And Dana, you have any questions from your side?
Yes.
A comment.
Thank you, Napa. These speakers, you're just fabulous. But I would like to just ask you all to just share with us. I noticed as in your presentations that you talked about action and your doses. And we heard from some of you talking about following national guidelines. Do you guys have established national guidelines in your country that you're following for dose limits in the IR? Or do you guys use regional, or do you use national, international? How are you implementing what your dose limits are going to be for your patients?
Maybe we start with Rabata.
Okay. It is a problem because in Italy we have no great indication, more indication about the dose limits for patients. We have a new regulation from August, but we are teaching about this regulation, so we need time for understand what is in this regulation. So at this time we are look at the past regulation or some indication by ICRP or Euratom directive. So we look at these for. So I think again I'm very lucky in my hospital because we look at Euratom directive from I think since about 5 years. So but it is our regulation, our Italian regulation is ready only for 3 months. So we are ready for this new regulation. And we look at these dose limits for patients for skin reaction. Sorry, for patients or we look at new papers about these those levels as a reference. It is enough.
Right.
Yes,
That's
it's
great.
difficult, but yes.
What about in South Africa about this regulation or per se?
Thank you. We do not have national guidelines or regulations. We follow the international ones, mostly the IAEA and the ICRP. But in 2020, there was a group led by medical physicists that was going to start looking the national DRLs. So hopefully that data is going to result into some sort of regulations for the dose limits in South Africa.
All right. In Myanmar, do you have anything like those limit for workers, like for yourself?
Yeah, actually, for about question, we have so far no patient complaint about the overdose or IR. We have the radiation law. Actually, at the moment, no specific guideline for IR in Myanmar. Yeah,
Wow.
that's all.
Just to share from my country, as
Yes.
we are the United Nations member state, so we at least we have to have a law or regulation that meets the requirement of the International Basic Safety Standard, the BSS. So that's going to be two arms: one to the radiation worker, the occupation and dose limit. So pretty much we follow the ICRP. But for the patient, there's no dose limit. Then we have the diagnostic reference level. We managed to have diagnostic reference level to all the modalities already, and interventional radiology is coming soon. I think by the end of the year we will have the DRL for interventional radiology. That answer your question, Donna?
Yeah, I have one more question, if you don't mind, Napa, for all you experts out there. So between our talk last time on interventional radiography and with our speakers now, just fantastic information. We get some conflicting information about the use of wearing a lead cap, whether it is good or not good, marketing out there, discussion about how great it is, and also about the lead eyewear, that wearing the lead eyewear. Should you use the lead eyewear that has wraparound because of scatter, or is just a plain lead glasses good without the sides on it? And so I'm curious from our radiographer experts around the world about those two types of protection. We heard about the lead aprons, but how about that? Is it, are they beneficial? And if they are, which one is better, the wraparound eyeglasses or just the plain eyeglasses? I think it's good to have some best practice information for our radiographers around the world that are looking to train them for their departments.
Yeah. Roberta, maybe you share first about this.
Okay. I think cap or other devices such as gloves on drapes, lidded drapes, are useful for reduce exposure. Yes, but we don't use them because they come with drawbacks, including stuff physical discomfort. So also we think that yes, you can reduce operator dose with these devices, but you need to understand when you can use them and when not, because I think it depends of the interventionist, the person, the health professional that use this device. We always in our department we use always thyroid shields or lid aprons or eyeglasses, lidded eyeglasses. We are not able to use for example, shieldings because there are a particular situation when there is not possible of using it. For example, when the primary operator is required to stand in close proximity to the patient, yes, you can use lid apron, you can use thyroid shield, but you cannot use other shields because you need to stay and you need to be in a comfortable position. So I think it depends on the health professional and above all of the interventionalist that is the primary operator, and it is more involved in this procedure.
All right. And how about in South Africa?
Okay, we I haven't seen anybody with the lead cap yet in South Africa.
Okay.
And lead glasses, as I mentioned in my presentation, are optional. But we do encourage the use of the ceiling-mounted lead shield because that reduces the scatter to the staff quite significantly. Because the thing about these lead apparel is that they can be quite heavy and they're going to result in some discomfort. So you wanting, especially for the long interventional procedures, you wanting to sort of have a balance between safety or protection and comfort to be able to, do it for the required length of time.
All right. In Myanmar, do you have like special lead cap?
In Myanmar, all radiographer will cap achieve full protection.
That's good.
Yeah,
I think so. And I think we come up to quite a good time, 1 hour and 15 minutes. I'm so sorry that Terry he got technical difficulty and he could not be with us today. I'm sure he will be back for the next episode. So I just want our Madam President Donna Newman to say something before we close the program for today.
Well, I want to thank all of our members from around the world that tuned in to learn from our experts that were on this panel. This has been just the best opportunity for radiographers to network and share best practice. So I can't thank you enough, you speakers shared with us from around the world. And I can't thank you enough for the people that tuned in to hear about what is happening in So thank you everyone for spending some time with us today, and we look forward to our next Facebook Live session, which will be in 2 weeks. And so goodbye to everybody, and I'll turn it back over to Napa to give the final words.
All right. So on behalf of the SRT, I would like to thank all the speakers for today. We have been enjoying your talk and your conversation with us. And of course, I know that our colleagues from all around the world, we are a big ISRT family. We are very, very happy to have you all here. And thank you very much. And also for the audience, I wish you have a good day. Goodbye. Thank you.
Bye-bye. Thank you.
Thank you. Bye.